Hello. Welcome to the Impact Education PayerTalkCE program entitled Understanding Type 2 Inflammation, Spotlight on Asthma. My name is Jeff Dunn. I am the President and CEO of Cooperative Benefits Group, which is a transparent PBM based in Salt Lake City, Utah, and I will be moderating today's session. This PayerTalkCE program is jointly provided by Partners for Advancing Clinical Education and Impact Education LLC. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi, and we would very much like to thank them for their support. At the conclusion of today's program, you will be able to complete an evaluation which must be submitted to receive credit. Click the Complete Evaluation link in the navigation within the activity. Once you complete your evaluation, you must click Claim Credit to download your certificate, or for the pharmacists who are participating, submit your credit to the CPE monitor. Today's learning objectives are, first, to describe how type 2 inflammation plays a central role in asthma pathophysiology, and second, to summarize safety and efficacy of evolving treatments for patients with asthma. I am joined today by Drs. Andrew Tripathi-Peters and Michael Kobernick, and I will turn the time over to them to introduce themselves. Dr. Peters, do you mind starting?
Sure. Thank you very much. I'm Anju Peters. I'm an allergist at Northwestern University in Chicago. I take care of mostly adult patients and focusing on both chronic rhinosinusitis and comorbidities. So a lot of asthma, since sinus disease and asthma goes hand in hand.
Thank you. And Dr. Kobernick.
Hi, nice to meet you. Dr. Peters, I'm Michael Kobernick. I'm a senior medical director of Blue Cross of Michigan. I have a couple areas that I work on. I work on all things coverage related, so I help with developing policy for medication use. I help with new market solutions, and I help lead the population health strategy for the organization. In addition, I teach at Jefferson College of Population Health. I teach health economics and finance, and I spend a lot of time in my job advising employers on strategies for managing healthcare benefits.
Thank you both so much. I'm really excited for this conversation. We have two fantastic people here ready to teach us about this topic. So thank you again. So going back to our first learning objective around describing how type 2 inflammation plays a central role in asthma pathophysiology, I would like to ask Dr. Peters a question. So Dr. Peters, how does type 2 inflammation contribute to the pathophysiology of asthma? And what are the key cellular and molecular mechanisms involved in this inflammatory process?
So Jeff, that is a really good question. When we think of inflammation and asthma, we know asthma is a very heterogeneous condition, very common. Two types of inflammatory patterns that are seen in asthma are type 2 and non-type 2. We'll focus on type 2 today, mostly because we have good treatment options for type 2 inflammation. So your question about how it contributes to pathophysiology of asthma, it's important to note that when we think of asthma, we think of the airways being inflamed. The epithelium or the lining of the airways is messed up, so it's leaky. We call it disrupted barrier. In addition, we see a lot of mucus production. One of the things, especially with severe asthma and people who die of asthma, you see mucus plugs. That is a big part of asthma. So mucus, and then the muscles get thicker, and there's just little stimuli that can make the airways more twitchy. Type 2 inflammation often underlies much of this that happens. So if you just think of the airway epithelium, the epithelium is faced by allergens, bacteria, viruses, etc. The airway epithelium releases something called alarmins. These molecules then lead to activation of our T cells to become more Th2 type. In addition, there are cells called ILC2 cells that get activated. These release cytokines IL-4, IL-5, and IL-13. IL-4, IL-5, and IL-13 are key cytokines in type 2 inflammation. IL-4 and IL-13 play a role in IgE production. IgE is our allergic antibody that sits on mast cells, basophils, An allergen may cross-link it. The mast cell then release mediators that can cause inflammation. That's classic of asthma. IL-5 is our eosinophil survival factor. It increases eosinophilic inflammation, and eosinophils play a huge role in asthma. They play a role in airway hyperresponsiveness that we see in asthma. They play a role in then releasing things that cause some of the inflammation we see in asthma. And then IL-13 plays a role in mucus production and also in airway remodeling. So these three cytokines are the typical type 2 cytokines that are important in type 2 inflammation. And they play a role in many other cells that get involved in asthma. I've given you just a very brief overview.
No, that's super helpful, and that's a great overview. You are talking to a payer, and a lot of the payers who are listening to us today, I think the question is going to be, how does this translate into what we do and the decisions we have to make? So how might understanding what you just described and these mechanisms influence the therapeutic strategies for managing asthma? So how do we use this to make therapeutic decisions?
I think that is also a very good question. And one of the first things that I mentioned earlier, we know we can treat type 2 inflammation. Even going back to inhaled corticosteroids target type 2 inflammation, and we know they work well. However, there's a small subgroup of patients, those with severe asthma, that despite using inhaled steroids, they continue to have asthma exacerbations. Their lung function continues to decline. They don't do as well. And many of these patients also have other what we call type 2 comorbidities, so atopic dermatitis or chronic rhinosinusitis with nasal polyps. We really want to target type 2 inflammation in these patients. In addition, eosinophils was one of the things we had talked about earlier. These release things that cause inflammation. Blood eosinophil numbers. The higher the blood eosinophil numbers, the more likely someone's asthma is likely to exacerbate. You can also check eosinophils in the sputum or in the lungs, but just getting it in blood, which we all can check easily, tells us it's a prognostic factor as to how someone's likely to do. So that's where type 2 inflammation works. There's something called FeNO, which is fractional exhaled nitric oxide, released by airway epithelium. It's a marker of inflammation in your lungs. Tells us someone is more likely to respond to steroids, potentially have exacerbations if FeNO is high. We know we can target this type 2 inflammation, so it tells us how someone is doing. Now, you as a payer care what we use. Inhaled steroids work in most. They're very safe, but high-dose inhaled steroids can have side effects. However, if someone, despite inhaled steroids and adding other things like long-acting beta agonists, is having exacerbations, we have drugs called biologics that target the specific type 2 inflammation that is responsible for asthma not doing well. So one of our oldest biologic is a drug called omalizumab, which targets IgE. It's been around for, I think, 20-some years. It has shown to decrease asthma exacerbations. It has shown people's symptoms to get better. We also have biologics that target IL-4 and IL-13. Remember, IL-4 was the cytokine that was important in IgE, the allergic antibody production. IL-13 was important in mucus secretion and airway remodeling. There's a drug called dupilumab that targets IL-4 receptor alpha that is shared both by IL-4 and IL-13 signaling. It is shown to decrease exacerbations, including in people who are steroid dependent, some of our most severe asthmatics. It decreases the need for oral steroids. It decreases exacerbations. It improves symptoms. Dupilumab is also approved for nasal polyps, which is a common type 2 inflammatory condition seen in patients with severe asthma. Then two others I want to mention. IL-5, the eosinophil survival growth factor that's responsible for eosinophils going from bone marrow to the target organ like the lungs. We have drugs that target IL-5. Mepolizumab has been around since 2015. It got approved. We have reslizumab, which is an IV version of anti-IL-5. We also have benralizumab, which targets IL-5 receptor alpha. All of these drugs target eosinophilic inflammation. They decrease asthma exacerbations, Mepolizumab and benralizumab also in patients who are systemic steroid, oral corticosteroid dependent, decrease the dose of systemic steroids, decrease exacerbation, improve symptoms. Mepolizumab is approved for other type 2 conditions, such as chronic rhinosinusitis with nasal polyps, EGPA, which is a severe condition seen in asthmatics and those who also have sinus disease. And then lastly, our newest biologic is a drug called tezepelumab that targets one of the alarmins that's released by the airway epithelium. It targets TSLP. TSLP is one of the alarmins that leads to type 2 inflammation by activating the ILC2 cells, activating T cells to become Th2 cells. We know TSLP is increased in severe asthmatics. So if you target TSLP, you improve severe asthma, decrease exacerbations, improve symptoms, and including improved lung function. So we really have good drugs that target type 2 inflammation, especially in our severe asthmatics. And we know up to 70 to 80% of our severe asthmatics have type 2 inflammation.
Thank you. That is a great summary for how the different specialty medications we have fit into this topic. And yeah, I think our payer colleagues are very concerned about appropriate utilization and how we really target these particular products to the right patient. So thank you very much. So
Can I say one more thing?
Absolutely.
Sorry to interrupt. So I told you that these drugs are great for severe asthmatics. Some of them are also approved for moderate severity asthmatics. And one of the things we should always remember about asthma, we're taught mild, moderate, severe, but even the mildest of asthmatics can have severe enough exacerbations that can be life-threatening. So it's important to note that patients can change how they do depending on what kind of allergen they're faced with, if they're around viruses, etc. So these drugs are really good for those patients who continue to have exacerbations, some of them for moderate asthmatics, some for severe.
Thank you for that clarification. So Dr. Kubernik, you wear a lot of hats. So you're on the payer side, on the provider side. So I want to ask you, given what we just heard from Dr. Peters, what do you see as the clinical and payer implications of this topic?
Well, thanks for asking. On the provider side, I did forget to mention, I spent 30 years as an emergency physician. And so I treated a lot of these patients in the emergency department. And really, the quickest way to get these individuals good care was to get them in charge of an allergist. So once we referred some of these patients who had varying degrees of asthma to the allergist, we never saw them again in the emergency department, which is a credit to that specialty and their overall approach to the patients. It's an important chronic disease. Lots of people have it, and there are some significant socioeconomic variations. Part of my work, as I mentioned, is in the population health space, and one of the things I know is that we don't get to the best outcomes unless we address the social determinants of health. So here in asthma, lots of people are struggling with access to care, access to medication, understanding medication, understanding how to take it, being able to afford it, getting transportation to the doctor. So those are all important issues for us to be aware of, and for health plans and payers to make sure that they're assisting in that space. I think that we see lots of the asthmatics that are poorly managed in the emergency departments, and that's to nobody's credit, because those treatments are rescue treatments and they don't get to the importance of prevention. I think that as we think about the evolution of treatment, which we heard so eloquently around the T2 inflammation and defining this as an inflammatory disease, I think that payers are challenged, as you mentioned, Jeff, with knowing which drug to use when. Our medication approval process stems from the FDA, which tracks back to the research trials. And so we want to make sure from a payer perspective that individuals are getting appropriate care prior to the administration of more complex medication. So the implications are really understanding from a payer perspective, I think understanding the social determinants of health and making sure they're addressed, making sure as part of any prior authorization process that appropriate initial treatment's done so that individuals that are treated with inhaled corticosteroids, for instance, are appropriately managed and understand how to use them, and that the prescriptions for severe asthmatics are written by specialists in the area.
Great, thank you. Yeah, as I said earlier, I think payers are going to be focused around appropriate utilization. We define value as comparative outcomes divided by comparative cost. And so these, relative to a lot of other specialty medications we deal with, these are not that expensive, but they're expensive. And this is a very, very large disease state in terms of prevalence. And so this is high on the radar screen. And plus we have all of the quality metrics and everything else involved. So super important topic. And that's really good information.
One thing which I'm sure you guys are all aware of, we know this subgroup of especially severe asthmatic is a minority of our asthmatics. It's probably around 5%. But this is the group that goes to the ERs, goes to urgent cares, gets hospitalized. And this is where the cost just goes up. I do think they drive the cost. So I totally agree with both of you guys that we should use these drugs responsibly in the people who need it. I do think in the people who need it, these have revolutionized treatment. I remember when I first started 20 some years ago, I had quite a few people. I would say like 10% of my patients were oral systemic corticosteroid dependent. And all of the side effects of those systemic steroids were terrible. People would get fractures, people had osteoporosis, people had cataracts, people had avascular necrosis, on and on and on, type 2 diabetes. Now I have maybe 2 or 3 people who are systemic steroid dependent. And now we even worry about high dose inhaled steroids causing potential side effects, which they can, especially in kids. But so I think using it in the right population makes sense. I also understand Jeff, and I think I'm not sure which of the payer groups explained it. We all don't want our premiums to go up, but we also want to do the right thing.
Yep. That's the balance and the tension we all face. That's a good description of that.
Yeah, but we know there are a lot of direct costs associated with this in terms of exacerbations and ER visits and hospitalizations. And so, looking at the big picture, there is an ROI by using these medications. But again, it's about using them in the right patient and at the right time and finding the right option for the right situation. And that's where it's a little bit of a challenge within the constraints of a formulary. So again, great conversation. I appreciate that. So I want to go back though, Dr. Peters, you kind of introduced this when you talked about the different MOAs and the drugs, but I want to take a little bit deeper dive into that. Really, the question is, can you reiterate what the therapies are for improving the management of asthma by type 2 inflammation? And then really building on what we just talked about, given the different MOAs and everything else, how do we use this concept and the different pathways or MOAs to find the right drug for the right patient?
I think that's a really good question in terms of we have these drugs. We want to use them responsibly. We want to use them on the right person. And, Michael brought this up. That depends who's the right person for it. So what we have national and international asthma guidelines. Our international guidelines, GINA, give us a really good framework of when these drugs should be used. So we do what's called step-up therapy, and there's track 1, track 2, and the guidelines help guide us. If you have someone with mild asthma, potentially you could just use inhaled steroids with a long-acting beta agonist with formoterol and budesonide on an as-needed basis. And then you step up. You may then start them on a low-dose maintenance inhaled corticosteroid with formoterol. And if they still are not controlled and are having symptoms, exacerbations, you could go to medium-dose inhaled corticosteroids with formoterol. But despite that, if they're not controlled or having exacerbation, the step 5 of GINA is where we then introduce these biologics. You would potentially try even high-dose inhaled steroids with a long-acting beta agonist and a LAMA or long-acting muscarinic acid blocking agent. And then if you do that and they're not controlled, then potentially you would decide which biologic to use. If you've added a LAMA, you have them on ICS-LABA, you're making sure they have true asthma and not something else that mimics asthma. You're making sure they use their medications correctly, what they're on, their inhaled steroids. correctly. You make sure you get rid of the, treat their underlying other type 2 comorbidities. You make sure you treat their allergies. I do think seeing a specialist at that time is important. Then, depending on some of these biomarkers, what's underlying their asthma, you would then consider using a biologic. So, for example, if you had a kid who was very allergic to environmental allergens and did not have other comorbidities or had comorbidities that could be targeted by omalizumab, I would consider omalizumab as a biologic. While if you had a patient who had eosinophils that were high and had asthma that was not well controlled, I would consider one of the anti-IL-5 drugs, or potentially even dupilumab or tezepelumab. And if I had someone with nasal polyps, and 1/3 of our severe asthmatics can have nasal polyps, we know dupilumab, which targets IL-4 receptor alpha, is our best drug for nasal polyps currently in those who have polyps that are not well controlled with nasal steroid sprays. And if they have asthma with it, I would consider dupilumab. And then lastly, if someone had what we consider type 2 and potentially non-type 2, which we don't have good treatment options for, I would consider tezepelumab because based on biomarkers, it also worked on individuals whose eosinophils were low and whose FeNO was low. And these biomarkers also help guide us. So there are many ways of looking at it. I think that that's quite complex. A specialist can help you decide it. I'm just giving you a brief overview.
No, I appreciate that. And I think that's where the rubber hits the road. And I admit, personally, I struggle a little bit when we talk about guidelines, because a lot of times guidelines, when they say, for example, if you have disease X, there's these 6 options, use one of these 6 options. That, with my formulary management hat on, that's not super helpful. And so I think a lot of payers are really looking for more granular recommendations. So if you have X characteristics, use this drug. If you have Y characteristics, use this drug. So, but it sounds like the guidelines that you're referring to do kind of break it out that way, right? It's more prescriptive, so we can better understand what is the right drug for a specific type of patient, right?
Well, I agree with you. So the guidelines give us broad, general guidelines, right? So they'll say you can use, if you have step 5, you could use anti-IL-5, you could use anti-IL-4 receptor alpha, you could use anti-IgE. I think that part, then deciding which one to use, often is not very simple, and more than one drug may meet the criteria for a person. A person may have more than one thing that more than one drug could treat it. And this is where us knowing what a formulary covers helps sometimes, or this is the art of medicine, right? Those of us who know a lot of this background on which drug works best for which drug works for more than one condition. I do think specialists are educated on this. We're trying to inform our other specialty colleagues too. I do think that's when we help kind of make the decision. And sometimes I will tell you it's frustrating as a physician to request and prescribe a drug and then find out that one's not covered. We often, I think, put in thinking to it as to why we're recommending a drug. I think we need to work together on this. I could give you examples if you want, but that's a hard one.
Yeah. Well, I think you hit the nail on the head is, and Dr. Kubernick mentioned this as well, why it's so important to have a specialist involved in this, because once you get to this point, it's crucial. And it just underscores the importance of having this open communication because, we have to make formulary decisions from a population perspective. And so we need to understand, the nuances in why you are choosing certain things. And that if it's not well understood, then, we're going to potentially do things that are counterproductive and counterintuitive.
I will tell you, I often will. Many of these drugs are very expensive. I don't want to put anybody on them unless they really need it, especially because the longest these drugs have been around is 20 some years. Others haven't been around that long. I don't want to put someone on something that they could have side effects down the road. They are very safe compared to biologics for other conditions. Often with prior authorization, we do get a chance to write it in a letter form why we are recommending certain drug. And I have to say, most often, even though that's kind of a painful process, most often it works. And I think the payers do understand and approve the drugs.
Perfect. And I think it's that communication goes both ways because we have a financial responsibility to manage budgets for our health plan and employer groups. And so just, teaching, or not teaching, but having conversations with providers about what we do and why we do is important, just like having those conversations with the providers about why a particular drug is a better choice for a specific patient. So that open communication, I think, is one of the take-home points that we want to make today is, end of the day, we're working together, and whatever we can do to facilitate those types of relationships, I think, is well worth it.
Mm-hmm.
Dr. Kobernick, did you have?
I would agree with that, particularly around when I look at our prior authorization criteria, for instance, for some of the biologics in the treatment of asthma. It's really just validating and confirming that current guideline treatment has been applied appropriately to the patients. And I think that as you describe our fiduciary responsibility to our customers and to our employers, we also have a clinical responsibility, because to make sure that the steps that are being taken prior to the administration of these medications are clinically appropriate. And so I think, and that's really reflected. And when I look at the prior authorization criteria for a variety of the medications we're talking about, it is pretty straightforward from my perspective. I agree that from a practicing physician point of view, it does take quite a bit of time and is a source of consternation by the treating physicians. But on the other hand, it allows us to attend to our, both, Jeff, as you say, our fiduciary and clinical responsibilities.
Perfect. So maybe we can just build on that and kind of wrap this up before we go to our Q&A section. And so, Dr. Kobernick, maybe you can take a little bit more of a deep dive into, how you view guidelines, where do you see these newer treatments fit? And then, how do you look at medical versus pharmacy and total cost of care? And, what is really the potential here to reduce healthcare resource utilization?
Well, so I guess the way I describe this to the employer groups is that healthcare costs, they always want to know why healthcare costs are going up. And generally speaking, it's the 2% of people spending the 40% of the dollars. And those are high cost claimants. And in that group of high cost claimants, about 50% of them are high cost oncology medications. Another 20% are the whole group of biologics. And so about 75% of healthcare costs increase because of high cost medications. And so that becomes an important question around the application. Are we doing everything we can to make sure that the medications prescribed are appropriate? In the conversations about formulary coverage, and I'm sure it's the same at your organization, it really has to do with what has the FDA approved and what were the studies that were done to support the medication utilization. The only time that there becomes a preferencing, which is like we prefer one medication over the other, is when the studies show they're clinically equivalent, or kind of the opposite, which is that there's no study to show one is better than the other. Then it creates a contracting or negotiating opportunity for the contracting team to determine a preferred agent that perhaps they're getting a better price on. And so that's kind of how I look at the landscape. Let's make sure that the appropriate clinical therapy has been given before one of the biologics. I call it, what we do is clinical and logistical vetting. And so we've done the clinical. Logistical is it being administered in the best location at the best contracted price.
Perfect. So how I would kind of summarize this, and then you guys can maybe chime in, is we have good guidelines here. This is an important disease state, very prevalent disease, but the biologics play a specific role in reducing exacerbations. But the key is working collaboratively with our specialists to talk about both clinical and financial, and finding the right drug for the right patient at the right time, and managing the cost. But by doing that, we will definitely improve outcomes, again, by focusing on those patients who really need these medications. Any last comments? I'll just open it up to both of you before we turn to the audience questions.
I mean, I can start. I do. You just summarized it very well. These drugs have revolutionized the treatment for asthma, which is a really common condition, affects from babies to elderly. It can cause long-term consequences. People can die from asthma, and people do die from asthma. These drugs have been amazing if we treat the right person who's being treated correctly with the right drugs, and then eventually if they need biologics, these have been tremendous. And potentially, now we think about potentially could these drugs put people into remission with asthma? Could it even be disease modifying? Over time, we will understand that part. So I do think open communications, using it in the right person is really important.
Perfect. Thank you. So at this time, we will now address those questions that have come in.
It looks like we have a couple questions that are in a similar vein. So I am going to start with you, Dr. Peters. The first question is there comparative data with the pharmacological treatments, probably the biologics, in terms of outcomes? And then the second related question is there comparative data on these agents in terms of adherence?
So in terms of comparative data on biologics, there are some studies that compare them. They're not direct studies, they're indirect studies. What I would say in general, these biologics decrease exacerbations, which is what they're supposed to do, by about 50%. Some work better in some patients, and this is where the biomarkers help. So for example, if they have high, what we call FeNO, exhaled nitric oxide, or high eosinophils, then we know that dupilumab or tezepelumab would work well. But if you also have high eosinophils, then potentially the anti-IL-5 targeting drugs would work well. So mepolizumab, benralizumab, or reslizumab. Omalizumab too. So they all work well. The comparative data, really, we don't have direct head-to-head studies. And then I think you asked me about adherence to biologics.
Mm-hmm.
These biologics have also not been around that long. Adherence studies, there are a few that are done that some patients are more likely to stay on them. Those whom these biologics are effective are more likely to stay on them. Unfortunately, costs are an issue. So if people cannot afford them, they tend to, and they don't get insurance coverage or they don't have insurance, then they're less likely to stay on them because these are very expensive drugs. What we do know is that if someone is on a biologic and because they're so expensive, we tend to see how effective they are in these patients in 4 to 6 months. And if they're not effective, we either stop them or change them to another one because a different one may work if one doesn't work.
Thank you. And there's another question that came in that is similar to that, but I'm going to come back here in a minute and kind of follow up on that treatment guideline or pathway. But there's a question here around type 2 inflammation. So I'm going to ask you, Dr. Kobernick, to start on this one. Since you kind of focused on type 2 inflammation generally, what is the role of type 2 inflammation in the cause of exacerbations themselves?
That question for me, Jeff?
Yes, if you wouldn't mind starting.
Yeah, well, I think that the type 2 inflammation is a newer area of understanding. And I think that from a medication management perspective, we're really not distinguishing those from the payer side unless it's called out in the prior authorization criteria as a result of the FDA approval indication. So if it's indicated for type 2 inflammation, then it'll be covered. If not, if the coverage isn't that specific, then it will default to asthma coverage.
Dr. Peters, is there this is probably a naive question, but maybe digging down into the question that was asked, does the type 2 inflammation have a different role in terms of the asthma progression versus exacerbations, or is it kind of a similar thing? If that's even a right question.
Well, I think the question that does make sense, which you're asking, is does type 2 inflammation play a role in exacerbation?
Yeah.
Yeah, I think we have enough evidence that some of the biomarkers that to us are markers of type 2 inflammation, just like Dr. Kobernick said, asthma could be it's newer type way of us thinking of type 2 versus non-type 2 inflammation. But type 2 we typically think of as with patients who have eosinophilic inflammation, allergic type inflammation. And yeah, we do have data that suggests that if your eosinophils in your blood are high, and they're easy to check, that you are at higher risk for asthma exacerbation. Same thing with exhaled nitric oxide or FeNO, which many of us who are specialists now use it. It may tell us if your FeNO is high, you might be at higher risk for exacerbation, or potentially if you do exacerbate and your FeNO is high, then these drugs and even inhaled steroids and oral steroids might work well.
Thank you. So speaking of biomarkers, how good are the biomarkers in terms of picking a therapy, and how does that relate to efficacy? So if somebody has a biomarker and we target it, is that drug going to work all of the time, or how close to all of the time is it going to work?
Do you want me to go for this one?
Please.
Nothing is 100% sure. We all know that in life, right?
Yep.
Biomarkers in general are pretty good. The eosinophils especially, which is easy to check. And eosinophils we check in blood. In research setting, they also check it in sputum. And those are a good marker that you're at higher risk for exacerbations if they run high. But do they work in everyone or predict asthma exacerbation in everyone? No, none of these are 100%. But they do give us a good way of getting to personalized medicine.
Thank you. So there's a couple of questions around dosing. And so this is the one I promised I would come back to. The first question was around adherence. This one's a slightly different one, I think. So if somebody is on a drug and compliant with a drug, but they're well controlled, is there ever a situation where we would try to maybe get them off of that drug to see if it's maybe changed the course of their disease, or they could basically manage without the drug?
I absolutely think so. That's one of the questions people always ask me when we start them on biologics. And my answer to them is, just because we're starting it now doesn't mean this is forever. There are many things that impact someone's asthma. It could be that they had exacerbations because they got sick with viral infections and they had a bad year. They had young kids. Maybe they were exposed more to allergens. Something changed. Their comorbidities were worse. But I do think that in many people, once you treat them on biologics, for some conditions, we actually spread out the duration between doses. But I do think once someone's asthma is well controlled, it's a good time to think. After it's been well controlled for a bit, consider stopping. And of course, if it gets worse, you can restart it. It's something that we do.
So I'm going to go down a rabbit hole a little bit with this. I think I know the answer, but do you see a role in authorizations from a payer perspective addressing that? Or would you honestly just say you've got to leave us alone as a provider to do that individually?
I don't know, Dr. Kobernick, if you want to go for it.
I think if you look at reauthorization criteria, Jeff, I think what you see reflected there is all we're looking for is evidence that the treatment's working. So in this case, limited exacerbations would be a good marker for the effectiveness of a biologic in asthma. I think that, as Dr. Peters mentioned earlier, that what we want to do is, before they get to the biologic, of course, is make sure they've maximized all the other therapies that can occur. And I know that all the specialists do that. And that was germane to the comments we made around how important it is for specialists to help manage these individuals with moderate to severe asthma.
And I think one other thing that I think of, Jeff, is that if someone is controlled, the payer might know that, yes, this person has not had an exacerbation for the past year or something. There might be a lot more to that patient that you may not know as a payer that's in the history and the treating physician knows. So I do think it would be nice to have more guidelines as to when to stop. Sometimes you stop people, they get worse. So we need long-term data on that. But I do think being left to the treating physician, to me, makes sense.
Yeah. And that was the pitfall I was kind of dancing around.
Well, and that's our philosophy
right?
too, as clinicians at a health plan. It's really our philosophy is to support the member and support the clinician treating them, and recognizing that they're taking care of the patients, we're not. And so if we're honoring our responsibility to make sure the medication's appropriate at a high level, then we can leave the clinician to treat the conditions on an individual basis.
Yeah, and it goes back to that relationship like we talked about a few minutes ago. And to your point, Dr. Kobernick, most PAs are when time comes around for renewal, there's just some requirement that it's quote unquote working. So again, where I was trying to dance around is there ever do you ever foresee an opportunity where we would have like a stopping rule? So for example, without a guideline. So for example, if somebody hasn't had an exacerbation in 2 years, do we like say stop it and see what happens, or is that even clinically not? Do we even not want to go there?
I think that's part of the treating physician's clinical judgment, and I would leave it in their hands to make that determination. I think that they know their patients. They know that the ones that are stable because of the medication or the ones that are stable because their circumstances have changed or there are other factors in that. So the clinicians I know always are trying to minimize the medications people are taking, not maximize them.
I agree. I appreciate the answer. I just had to ask about stopping rules because it comes up a lot. So I was trying to preempt that question. The other question, going back to Dr. Peters, was around optimal timing of when these things are started. And I think we've talked about that a little bit, following guidelines and labels and things like that, and step up through controller meds and things like that. But how would you summarize, just generally speaking, when you consider starting a biologic in a quote unquote average or typical patient?
I think in an average or typical patient, and no one's average or typical, is if they're having exacerbations enough to need oral steroids. And to me, and again, everybody's different. One patient's one exacerbation may be severe enough that they're in the ICU, and I would start them on a biologic and probably leave them on for longer than I would in someone who's had more frequent exacerbations needing oral steroids. But if someone's had 2 or more courses of oral steroids in a year for asthma exacerbations and they're not well controlled, I think it's time to start thinking of biologics. And they're on baseline meds like inhaled steroids and long-acting beta agonists. So you're treating them appropriately, and they're still getting exacerbations and not feeling well controlled. Yeah, that's when I would think of starting it. And then you would choose the right one based on biomarkers, based on comorbidities, because some are for other comorbidities like we talked about, and potentially if you treat the comorbidity, their asthma might do better.
Thank you. So we had a couple other questions, but they were generally in the buckets of some of the questions we've already addressed. So I will start to wrap up here and maybe just ask each of you for closing comments, and really specifically ask you, Dr. Peters, to start. You have a bunch of payers listening right now. As a provider, as a specialist in this area, is there anything you would like to say in terms of how we could help you better? Again, walking that fine line between financial and clinical stewardship. What would you like to say to our audience?
Well, I would like to actually thank the payers because you know what? These medications are very expensive, but they've revolutionized treatment of asthma, as I mentioned. Asthma treatment has changed so much in front of my eyes from when I was a fellow and a junior attending to now. I hardly ever need to put someone on oral steroids on a long-term basis. So I actually think these drugs are wonderful in the right people. We have a responsibility to treat the moderate to severe asthma, treat their comorbidities, work with our collaborators. And I think I'd like to thank the payers because as I mentioned earlier, yes, it can be work, especially prior authorizations. But if we think it's necessary, then, and I will tell you, once I do prior authorization, I don't think I've been denied completely ever. I've had to go through multiple reiterations, but never completely denied. So anything you guys can do to make our lives easier to treat these patients while we make sure we do it responsibly, we all can think of better ways to collaborate, but thank you.
You're going down a rabbit hole, you made me think of something. Have you ever been able to work with a plan or payer where you've been what we called gold carded?
What's that mean?
Where you have a higher credit limit. No, that's not what I mean. Right? Like where given your expertise and to your point, the fact that you pretty much get everything approved anyway, that you don't have to go through the PA process because you've demonstrated to the plan or the payer that you're managing our members, and we're going to call them members instead of your patients, appropriately.
I don't have that gold card. Believe me, I do a lot of prior authorization. And when I'm doing them, I'm being generous saying thank you because, I'm not doing one right now. When I'm doing the prior authorizations, it can become frustrating. Not the prior authorization part. It's just that we have to do prior authorizations for so many medications and people's insurance changes. So 1 year, one thing is covered, 1 year, another thing is covered. More so than biologic, I feel like I'm doing prior authorizations on inhalers, nose sprays. And when do I get frustrated? When patients and your members get mad at us. They think we are not doing our work. They get upset and then they send my charts. What they don't realize is that I work after hours doing things and writing these letters. We have 2 people doing prior authorizations in my allergy division. I mean, we work really hard at them. And so I think you guys obviously know this is hard work. It's your members who don't understand completely that. So I don't have a gold card. I wish.
Okay. I was kind of curious because we talk about it and we do it in other areas.
Right.
I
Yeah,
will use it responsibly.
Yeah, we do it we've been looking at it in procedures. I think it really starts with the bigger picture, which is that we are sensitive to the fact that prior authorizations are onerous for our clinicians. We know that. On the other hand, as you've displayed and what we've heard today is there's a tension between the fiduciary responsibility and that we have to, for instance, employers who are actually footing the bill for the healthcare and the physicians. So there's that tension that exists, and gold carding that is looking at the denial rates of certain physicians, certain physician group is being explored. We are sensitive to the fact that we don't want to require prior authorization on things that are going to be approved anyway. And so there's a lot of work being done in that space to minimize the inconvenience of the prior authorization and yet attend to the fiduciary responsibility that the health plans have.
Great comments. Thank you. And I think, Dr. Peters, you also, I just want to call out something you said as well, that we can't forget about the patient in the middle of this because it can be super frustrating. So they might have, so there's formulary issues, there's benefit issues, but just that coordination of care because they're talking to you, they're probably getting a call from us, they're probably getting a call from the specialty pharmacy, and so it's very confusing, and it probably causes problems. So if there's anything we can do to coordinate that, I think is probably a take home. Dr. Kobernick, I'm going to give you kind of the last word, and I'm going to put you on the spot a little bit. You straddle, so you have your feet in 2 different worlds. So is there any take homes that you would leave us with in terms of like best practice? How the plan can work better with the provider and make our patients put them in a better spot.
Yeah, I think I may have mentioned earlier that not only do I have a foot in each area, I spent 30 years in the emergency department taking care of these patients during their exacerbations. And so I think that the challenge really is that tension we describe, is making sure that people get the clinical services that they need at a price that's reasonable, that's affordable for the employer, and being mindful of the care fragmentation issues that everybody's facing. And we touched on the social determinants of health, particularly in asthma. Not everybody has access to care. Not everybody that has insurance can afford care. And so there's a whole host of issues that come under this area that we need to continue to strive to work on. And I guess that the closing comment is that the work we're doing in care management for all of our individuals with complex illness to help them coordinate their care across the continuum is really some of the most meaningful clinical work that we're doing. And I would encourage all of us to continue to develop those services.
Fantastic. Well, I would now like to conclude the webcast. Thank you, Dr. Peters and Dr. Kobernick, for your fantastic and insightful commentary. Once again, I would like to thank Regeneron Pharmaceuticals Incorporated and Sanofi for their support of this educational activity. For our participants today to claim credit please click the complete evaluation link in the activity. And then once the evaluation is completed and submitted, you will be able to select the type of credit you require. So again, thank you, everyone. Thank you for joining us today. Hopefully you found this informative, and I hope you have a great rest of your day.